Patients can do harm by waiting too long for a total shoulder replacement in probably one specific scenario. But in general, the way I like to make that decision on when we move forward with surgery is, are the patients ready for surgery? Are they well indicated for surgery? And will they do well? And one of the most important concepts is, can we do anything else shy of surgery first to get them an outcome without having to pursue surgery? And so we like to exhaust ice and anti-inflammatories when patients can tolerate them, maybe therapy, although sometimes that may cause more pain, injections, whether it's steroids, gels, biologics. And once a patient feels that they've exhausted these and is unhappy with their pain levels, their functional levels, at that point in time we may consider moving forward with surgery. The one caveat is bone loss. And when we're working with a shoulder in particular, this is the shoulder girdle, and on the socket side, on the scapula, there really isn't a whole lot of bone loss, and there is a subset of arthritis in which we start to lose that bone. And one of the worries is, as we lose that bone, we may lose the opportunity to reconstruct the shoulder. And as a result, when we see that one variant, I recommend that we follow through with x-rays every 6 months to watch it closely, maybe have a low threshold to obtain advanced imaging like a CAT scan, and that may be the one time I urge patients to move more quickly towards surgery than maybe their pain or function may dictate.